Hey guys, this is CT 4071, and we are still on lesson 2, imaging the thorax, but we are going to look at imaging the coronary arteries, the aorta, and bronchography in this lecture. We're going to split it up into two. It's kind of a long lecture, so I'll split it up into 2 parts this week. So we'll just begin here. So in this lecture, cardiac CT, we'll be discussing many aspects. Romans has a very thorough discussion of cardiac CT. Most of this lecture is going to come from that text, but we will be discussing ECG gating and the electrical system of the heart and the pharmacology courses in greater detail. So we'll cover them a little bit here, but not as well as we will in pharmacology. For years, coronary angiography in the special suite or in the cath lab provided the only method of imaging the coronary arteries. And although coronary angiography is a useful tool, it's invasive and associated with small but significant risk of complications, including stroke, bleeding, severe enough to require transfusion, vascular access complications, myocardial infarction, and even death. In addition, the procedure is associated with significant costs associated with personnel, equipment, additional costs related to the recovery time is needed after the arterial catheter removal, as well as the management of possible adverse events. And so for these reasons, coronary angiography is typically reserved for the patients with serious symptoms and have a high likelihood of having significant coronary artery disease. So, and also it's reserved for the patients they think they can intervene and do balloon angioplasty or place stents while they're there. So advances in CT and MRI are changing the established practices. Cardiac CTs emerged as a less invasive imaging modality for the diagnosis of coronary artery disease, or CAD. It's often used to avoid coronary angiography in low and intermediate risk patients in particular. Continuous improvements in CT detector technology and in temporal, which is speed, and spatial, which is thin slices resolution, has resulted in clinical results with cardiac CT that are similar to those with conventional catheter angiography. CVD, or cardiovascular disease, is the leading cause of death in the United States and accounts for approximately 37% of deaths back in 2003. It's a little old statistic, but it's probably still the same. Coronary artery disease is responsible for the majority of those deaths, but also included are non-coronary cardiac diseases such as congenital heart disease and other forms of acquired heart disease like valvular diseases, cardiomyopathies, tumors, and pericardial processes. Cardiac CT can provide not only anatomic information but also functional information to aid in the diagnosis and treatment of the cardiovascular disease. And our discussion of cardiac CT begins by reviewing the basic anatomy and physiology of the heart, because the technologist's understanding of structural anatomy and the path and timing of circulation is essential to create high-quality cardiac CT images. And from that foundation, we're going to consider the various technical aspects essential to performing those high-quality cardiac CT exams. These exams are pretty technical, and they require a lot of timing has got to be right, a lot of post-processing. So it takes a while to get these down, but it's not impossible. So let's start by talking about the valves and the openings in the heart. This may be a review for you, but it'll help you as we go along. Heart valves limit the flow of blood to only one direction, and they lie at the exit of each of the 4 heart chambers. So when open, the 4 heart valves ensure that blood flows freely in a forward direction. And when closed, the valves prevent blood from flowing backward to its previous location. When the heart valves open, they make a familiar lub-dub sound. The first sound is made by the tricuspid and the mitral valves, the atrioventricular valves, closing at the beginning of systole, which is when the heart contracts and pumps the blood out of it. The second sound is made by the aortic and the pulmonary valves closing at the beginning of diastole, which is when the heart relaxes and fills with blood. Each valve either consists of 2 or 3 folds of thin tissue. The 2 atrioventricular valves are the tricuspid and mitral valves. The appropriately named tricuspid valve has 3 of those thin folds and is in the right side of the heart between the right atrium and the right ventricle. The mitral valve has only 2 flaps and is in the right side of the heart between the right atrium and the right ventricle. So tricuspid valve here between left atrium and left ventricle, mitral valve here between the right atrium and right ventricle. Pulmonary and aortic valves are semilunar valves. It means they have a half moon shape, basically flap. Pulmonary valves in the right side of the heart between the between the right ventricle and the entrance into the pulmonary artery, which is here. The aortic valve is in the left side of the heart between the left ventricle and the entrance to the aorta, right back here. Aortic valve right in here. This chart, if you've taken my class, you're familiar with this, but this chart's a simplification of what we learned about blood circulation through the body. We've probably gone over this before, but blood from the superior and inferior vena cavas, and blood from the superior and the inferior vena cava flows to the right, from the right atrium through the tricuspid valve into the right ventricle. And from the right ventricle, the blood travels through the pulmonary valve into the pulmonary arteries and on into the lungs, where it's oxygenated. Then it returns back to the left atrium, then through the mitral valve into the left ventricle, and from the left ventricle, it's pumped through the aorta out into the rest of the body. Major vessels of circulation are the right coronary artery, also called the RCA. It provides blood to the right side of the heart, which pumps to the lungs. The marginal branch branches off of the RCA and supplies the right ventricle. So RCA is here, right side of the heart. Marginal branch branches off here, and then here's the RCA going around the back of the heart to the anastomosis of the circumflex branch off of the left side. The left main coronary artery, or the LCA, which is here, it's also known as the left main trunk, and it branches into the circumflex, which is here, and supplies blood to the left atrium and side and the back of the left ventricle. The other branch is the left anterior descending, or the LAD, which is here, anterior descending. The LAD supplies the front and the bottom of the left ventricle and the front of the septum. These major coronary vessels lie on the epicardial surface of the heart. Other vessels and arteries branch off from the major coronary vessels and penetrate the myocardium to supply the blood. Most of the blood supplied by the coronary arteries is returned to the right atrium via the coronary sinus. The branches of the coronary sinus include the great cardiac vein, which is also called the left coronary vein, the middle cardiac vein, and the small cardiac vein. So while we're discussing coronary arteries, let's talk about the coronary artery grafts and the stents that are placed. The buildup of fat and cholesterol plaque is called atherosclerosis. When the plaque builds up in the coronary arteries, a partial or a total blockage results and the heart muscle does not get an adequate blood supply. and therefore, or this is referred to as ischemic heart disease or coronary artery disease, CAD. CAD is one of the leading causes of death in Western societies, and according to the American Heart Association, CAD is the single leading killer of American men and women. Coronary artery bypass graft surgery, or CABG, CABG, as it's commonly pronounced, is typically recommended when there's a disease of the left main coronary artery or in 3 or more vessels, or if non-surgical management has failed. Technologists should be familiar with the basics of the procedure because it's a common indication for CT imaging, both in evaluating patients for possible CABG surgery and for assessing the grafts and the patency of the grafts after the surgery. Arteries or veins are taken from elsewhere in the patient's body, and they're grafted from the aorta to the coronary arteries to bypass atherosclerotic narrowings in the vessels and improve the blood flow and supply to the coronary circulation that's supplying the myocardium. So in this example, you have a graft coming from a vein in the leg, and it is attached to the aorta, and it bypasses this area of this right coronary that's got some disease in it, obviously down in here, so that it's bypassed and supplying the heart. Same here, it's going from, what is that branch? Subclavian off, and the graft is coming down and bypassing the LAD blockage or circumflex, whichever one's blocked up here, to supply blood to the myocardium. The terms single, double, triple, or quadruple bypass refer to the number of coronary arteries bypassed in the procedure. So the arteries or the veins used for the graft can be taken from different areas of the body. The choice is highly surgeon dependent. A common choice is the left internal mammary artery, which is also referred to as left internal thoracic artery. It's grafted to the LAD. Another frequent choice is use of Saffon's vein from the leg. Less frequently, they can use the radial artery of the forearm or the right internal mammary artery. Vessels used for grafts are redundant, which means that the body can compensate for their removal. Grafts may occlude in months to years after bypass without any significant graft stenosis of up to 70% in diameter. Another technique for opening other techniques for opening these arteries are balloon angiography and coronary stenting, and they're less invasive than CABG, and they are some options for some patients. Angioplasty is a technique that uses that's used to dilate an area of arterial blockage using a catheter with a small inflatable sausage-shaped balloon at its tip. However, angioplasty has its shortcomings. First, the opening created by the angioplasty is not very smooth. This is because the areas of stenosis are typically made up of both atheroma, which after the channel is expanded, which results in gradual restenosis of the vessel. Coronary artery stents were designed to overcome some of those things, and a common type of stent is made up of self-expanding stainless steel mesh, and it's mounted on a balloon catheter in a collapsed form. When the balloon is inflated, the stent expands and pushes against the inner wall of the coronary artery. And in many cases, the stent is coated with a pharmacologic agent that's known to interfere with the process of restenosis. And these stents are called drug-eluting stents, and they're often referred to as coated or medicated stents as well. So compared with angioplasty alone, stents open the disease segments into a rounder, bigger, and smoother opening and reduce the chance of restenosis. However, stents cannot be used in all situations. For instance, stents are difficult to place in arteries that have extreme bends, and they cannot be used in very small vessels. So we need to know what they're going to look like when we're finding them, and we'll go over that when we get there. So when doing a calcium artery score, which we'll talk about later, you probably going to see stents in there, and they should be recognized so that you can, they're not included in the images that are measured, because they'll artificially increase the score because they're not actual calcium. So that's why it's important to know what they look like, the stents look like. So the scan parameters for cardiac CT include 2 scans. The first scan is an initial non-contrast coronary artery calcification scoring scan. It's also called a CAC scoring scan. We're going to discuss those in just a little bit. The second scan is an IV contrast enhanced scan with 75 to 100 milliliters of contrast that's injected at 4 to 6 milliliters a second. And we're going to be using 2.5 to 3 millimeter axial slices extending from the aortic arch to the base of the heart. And then multiple reconstructed images are going to be submitted, including the NPRs, curved reformats, and the MIP images. Now, a CT chest also can evaluate the morphology of the heart chambers and the valves, the myocardial perfusion, or how the blood's perfusing the tissue, and the ventricular volume and ejection fraction, where you can measure how big the ventricle is, if there's some disease process going on there, and you can also measure the ejection fraction, which is how fast the ventricles pump the blood out. And also it'll show wall thickness and motion abnormalities as well. The initial non-contrast scan of the cardiac CT, called the CAC, is used to evaluate atherosclerotic disease, which is indicated by the presence of coronary artery calcification. And it can be a standalone exam as a screening as well, because it's really quick and there's no contrast and no invasive actions taken. But it's most often accompanied with the contrast enhanced cardiac artery scan. Cardiac CT is ECG gated. That means that the patient is connected to an ECG machine that feeds information to the scanner. And as the heart rhythm is monitored, the scanner is only going to scan when the heart's in diastole, and that's the resting state of the heart. And there's significantly less motion during that time. Heart rate has to be controlled for the CTA, the CT coronaries. The heart rate has to be controlled, and it is optimal to have a heart rate that's 65 beats per minute or lower. Sometimes to achieve that rate, we can use beta blockers, which are given to slow the heart rate. Coronary artery vessels are small, and unless contraindicated, sublingual nitroglycerin tablets are given as well to dilate those coronary arteries right before the scan. We'll discuss in more depth the ECG gating and all the pharmacological methods used in the pharmacology course. So the system you use to quantify the volume and the density of the calcium, which is what you're looking for in the CAC scan, is called the Agatston scoring system. So the CAC scale, I'll go ahead and define that. That's on your slide here. Agatston scoring system is used to quantify the volume and the density of the calcium within the arteries. The areas of calcium equal 1 millimeter squared in an area with the Hounsfield units above 130. But the CAC scale, what you're going to need to be concerned with is if their score is 1 to 10, and all your software figures this up, what you do is kind of you set your ROIs within those calcified areas and the sections that you want to measure, and it'll do it for you. So, but 1 to 10 is minimal, 11 to 100 is mild, 101 to 400 is moderate, and then greater than 400 is extensive calcification. So this image here is a typical slice through the left main coronary artery, and you can see the calcium deposits within the artery against the walls here and here. A stent would look totally different. It would kind of cover the whole artery. But what you have are these calcium deposits here and here, up here and down in here in this left main coming off. So what you have to be careful with when you're scanning these, a lot of times what you'll find is the plaque that's hiding behind and attached to these these calcified areas, and you can see it. You can actually see it on the contrast portion of the scan. It's really neat to see. I think we're going to stop there today. We'll pick up with the CTA contrasted part of the scan next lecture, and we'll look at some images, and then we'll talk about CTA of the thoracic aorta and bronchography. So we'll talk to you then.